So, my name is Jess. I'm one of the R2 anesthesia residents, for those of you who don't know me. And today I'll be presenting on perioperative neurocognitive disorders and the anesthesiologist role. So, some key learning objectives of this talk are to distinguish between postoperative delirium, delayed neurocognitive recovery, and postoperative neurocognitive disorder, identify patient-specific and procedural risk factors for PND, and apply preoperative stratification. And then lastly, to apply evidence-based strategies to reduce the incidence of post-op delirium and cognitive decline. So I want to open with a case presentation. This is the story of Mr. R. Mr. R is a 72-year-old retired engineer. He's sharp, he's independent, and he's socially active, and he's presenting for an elective total hip arthroplasty for osteoarthritis. His pre-op MoCA is normal. He lives alone and he's completely independent, including with driving and managing his own finances. His past medical history includes hypertension, type 2 diabetes, and depression. The intraoperative course is uneventful under GA and lasts 2 hours. On post-op day 1, Mr. R does not recognize his daughter when she visits. He becomes combative and screams at staff. Between these episodes, he stares blankly at the wall, unable to follow simple commands. His sleep is fragmented, and he's incontinent for the first time in his life. From day 5 to 7, Mr. R is oriented again and embarrassed by what the nurses described to him. But something's different. He can't remember his home phone number, and he asks the same questions repeatedly within minutes, and his daughter notices that he's foggy. And then at his 30-day follow-up, Mr. R's MoCA has dropped to 18 out of 30, which is a 7-point drop from his baseline. He's returned home, but he's no longer managing independently. His daughter has moved in after finding unpaid bills piling up, medications not taken properly, and even got lost driving to the grocery store that he's visited for 20 years. He's no longer able to read properly as he can't track a storyline, and his daughter describes him as a shell of who he was. 3 months later, Mr. R's cognition has only partially recovered. He's now fully dependent on his daughter for medication management, finances, and his driver's license has been surrendered after a near-miss accident. He's developed severe depression, and his old friends visit less frequently. He finds conversation very exhausting, and he asks his daughter, am I getting Alzheimer's? At the 12-month point, there's still persistent deficits in attention, executive function, and episodic memory. His cognitive trajectory now mirrors that of early Alzheimer's disease. He requires a home health aide, and his daughter has reduced her work hours. So the hip replacement was a technical success. He walks without pain, but Mr. R says he would not have had the surgery if he had known the cost. So why is this very long-winded story important? Well, over 40% of all surgeries are in patients over 65 years old, and perioperative neurocognitive disorders are the most common perioperative complications in older adults. PNDs are associated with prolonged hospital stays, loss of independence, and increased mortality. And a retrospective study looked at over 5 million inpatient admissions for major non-cardiac surgery and in over 3,000 hospitals across the US. And this study was published in JAMA in 2025. The no post-op delirium group was the control or reference group, and the delirium group was either an unadjusted odds ratio where the data was just adjusted for age and surgery, or an adjusted odds ratio where the data was adjusted for patient demographics, urgency, frailty, comorbidity, surgical procedure, and day of the week and year of admission. So the results are showing that patients with postoperative depression are 3.5 times more likely to have poor outcomes, such as death and major complications. In 2018, a new set of terms was established to describe the various periop neurocognitive disorders with the goal of aligning these perioperative cognitive terminology with the DSM-5 criteria. This nomenclature was established by this nomenclature consensus working group, and the recommendations were simultaneously published across 6 major journals in that same year. So now perioperative neurocognitive disorders, or PND for short, is an umbrella term for surgery-related cognitive change. And there's 5 subgroups now, which are pre-existing cognitive impairment, postoperative delirium, delayed neurocognitive recovery, post-op neurocognitive disorder, and just neurocognitive disorder. These terms differ by timeline. So prior to the OR are pre-existing cognitive impairments. Immediately after the OR, up until 7 days post-op, is now called post-op delirium. Up until 30 days is delayed neurocognitive recovery. And after 30 days until 12 months post-op is referred to as post-op neurocognitive disorders. Beyond 12 months is referred to as just neurocognitive disorders, and the post-op term is dropped. As you can see, this is different from the old nomenclature where there was emergence delirium, post-op delirium, and POCD, which are terms that are no longer used. There's several pre-existing cognitive impairments that put patients at increased risk of developing PND, mostly post-op delirium, and more research is needed for association with longer-term neurocognitive impairments. So the SciPod study found that 21% of older surgical patients had unrecognized cognitive impairment, and these patients with mild cognitive impairment were at approximately 3-fold increased risk of developing postoperative delirium. Patients with dementia have a 2.5-fold increased odds of delirium, and vice versa. Patients who experience post-op delirium without prior cognitive diagnosis have a 3-fold higher odds of subsequently being diagnosed with dementia, just like our patient in the case presentation. And for pre-op depression, I actually contributed to research on this topic. Our systematic review and meta-analysis looked at 42 studies pooling over 4 million patients over 5 continents. And we found that for patients with pre-op depression, the risk of delirium was 2 times greater compared to patients without pre-op depression. Patients with Parkinson's disease also have a 2-fold increased odds for developing postoperative delirium. And cerebral vascular disease is one of the most widely examined and consistent risk factor for post-op delirium. Patients with cerebrovascular disease are at 4-fold increased odds of developing post-op delirium, and it's also associated with longer-term neurocognitive disorders. For post-op delirium, it's defined as acute fluctuating disturbance in attention and awareness, and it develops over hours or days and can last up to 7 days post-op. So there's hypoactive, mixed, or hyperactive delirium, with the hypoactive subtype being the most common. There's different assessment tools to diagnose delirium, but the most common is the confusion assessment method shown here. The patient needs to have both features in category A and B plus either C or D, which is disorganized thinking or altered level of consciousness. Delayed neurocognitive recovery is defined as cognitive decline from baseline in one or more cognitive domains occurring post-op days 7 to 30. This is a separate entity from delirium. It's not characterized by fluctuating attention, but instead it's a decline in cognitive performance, such as difficulty with memory, concentration, and processing speed. The typical way this is described is that patients are alert and oriented, but they're just not themselves. For this diagnosis, there's 3 criteria that need to be met. One is presence of a subjective complaint by the patient or family or caregiver. 2 is objective decline on neurocognitive testing like the MoCA or Minicog. Mild decline is 1 to 2 standard deviations below norms, and major decline is over 2 standard deviations below norms. And then 3rd is evaluation of impact on activities of daily living, such as eating, dressing, bathing, etc. Post-op neurocognitive disorder has the same definition and diagnostic criteria as delayed neurocognitive recovery, except it's diagnosed from 30 days to 12 months post-surgery. If cognitive deficits persist beyond the 12-month mark, then the condition is reclassified as just neurocognitive disorder, and the post-op qualifier is dropped. As with DNR, patients often describe tasks as harder than before. In mild neurocognitive disorder, independence is preserved. Family members may notice the patient is slower, more forgetful, or less sharp, but the patient still manages independently. But then for major neurocognitive disorder, independence is lost, so that tasks that were previously routine now require a caregiver. And the same assessment tools are used here as well as in addition to assessing IADLs and patient and family interviews. So the incidence of these PNDs are high. Post-op delirium occurs in up to 65% of patients over 65 years old. Delayed neurocognitive recovery occurs in approximately 16% of patients at 1 month, and postoperative neurocognitive disorder occurs in approximately 10% of patients at 3 months and 3% at 1 year. This is just a brief overview of the pathophysiology behind PNDs. This illustration demonstrates the two-hit model in which pre-existing vulnerability, which is the first hit, interacts with anesthesia as a second hit, triggering downstream mechanisms, including neuroinflammation with microglial activation, oxidative stress with increasing reactive oxygen species, neurotransmission imbalance, blood-brain barrier dysfunction, and impaired synaptic plasticity. And then all of these contribute to post-op neurocognitive disorders. I want to highlight diabetes as a risk factor since it's so common. Patients with diabetes have a 1.5 to 2-fold higher incidence of PND. This heightened vulnerability stems from the synergistic interaction between the underlying diabetic state and the physiological stress induced by anesthesia and surgery. Chronic low-grade inflammation with elevated pro-inflammatory cytokines, metabolic dysregulation from hyperglycemia, and vascular impairment with the blood-brain barrier dysfunction, facilitating influx of peripheral inflammatory mediators, all together are the first hit, which creates a stage of heightened neuronal vulnerability, so that when these patients go for surgery, which is their second hit, the brain triggers those downstream dysregulated mechanisms that lead to PND. Other pre-op risk factors besides diabetes is sleep disruption, excessive alcohol consumption, polypharmacy, frailty, functional impairment, vision and hearing impairment, and so on. For intraoperative risk factors, any major surgery and prolonged surgery is known to be a risk factor for postoperative delirium and neurocognitive dysfunction. The lower half of the chart that's bolded is basically everything that we can control. And a lot of the same meds, when used in the post-op period, can actually precipitate delirium, but the data is unclear with intra-op use. And interestingly, anesthesia technique or agent is not a known risk factor, but there's some conflicting data there that we'll go through. So there are several major RCTs that compare regional to general anesthetics, looking at post-op delirium and neurocognitive disorders as primary outcomes. And this may come as a surprise, but there have been no differences found in any of the trials. I highlighted the 3 biggest RCTs here. In the Regain trial from 2021, they looked at 1,600 patients at 46 hospitals, and the regional group did spinals with or without sedation. That was up to the discretion of the anesthesiologist. But there was no difference in post-op delirium between the regional group and the GA group. And then in the RAGA trial in 2022, they excluded sedation in the regional group, and they still found no difference in postoperative delirium. The RAGA trial also did a follow-up study in 2025, and they did not find any difference in longer-term neurocognitive disorders at 12 months between the 2 groups. Even if we look at meta-analysis pulling together a greater number of patients across studies, there was still no difference found in both post-op delirium and later neurocognitive disorders. In fact, I couldn't even find one study that showed a significant difference. So overall, the conclusion here is that the decision between regional versus general anesthesia should not be driven by concerns regarding PNDs. So another anesthetic technique that has been researched is comparing TIVA to inhaled volatile anesthetics. There's one major multi-center RCT and then a lot of smaller single-center RCTs showing similar mixed results. So from the one large study called the Sudoku trial, they looked at over 1,000 patients undergoing cancer surgeries and randomized them to either TIVA or SIVO. They found TIVA reduced post-op delirium by 1/3, but the benefit was mostly on post-op day one. And they found no difference in cognitive function at 30 days or 3 years. Sorry. When looking at meta-analyses of all the small RCTs pulled together, there seems to be no difference in post-op delirium if that was assessed, but there did seem to be a difference in delayed neurocognitive recovery favoring TIVA. However, these meta-analyses were analyzing very heterogeneous studies, which makes it difficult to pull these studies together. These were all classified as low-quality evidence due to wide confidence intervals, which were likely due to that heterogeneity and also risk of bias from lack of blinding and inconsistency on how DNR was measured across studies. So the results of the large RCT are conflicting with these meta-analyses with opposite conclusions. So overall, for TIVA versus volatiles, the data is inconclusive and more high-quality data is needed to make any claims. Another anesthetic technique that has been researched is EEG-guided anesthetic depth, mostly with BIS monitoring. So there's 3 major trials, but they also have conflicting results. 2 trials against EEG guidance are the Engages and Engages Canada trial. The first trial looked at over 1,000 non-cardiac surgery patients. They used SIVO and BIS monitoring for all patients. And although they reduced burst suppression in the BIS group, there was no difference in post-op delirium between the 2 groups. In the Engages Canada trial from 2024, again, the study looked at over 1,000 patients, but this time they were all cardiac surgery patients. They used the same methods as the first trial, where the clinicians in the guided group were encouraged to decrease anesthetic depth when burst suppression was present or when the EEG index fell below recommended thresholds. And again, there was no difference in post-op delirium between the 2 groups. On the other hand, the CODA trial from 2021 was another multi-center RCT, smaller than the Engages trials, but patients were randomized to either light anesthesia, targeting a BIS of 50, or deep anesthesia, targeting a BIS of 35. Type of volatile agent was at the discretion of the anesthesiologist, so SIVO and DES were used, and BIS was used to titrate to the assigned target. They found a 42% reduction in delirium in the light anesthesia group, as well as reduced neurocognitive disorders at 1 year. So in conclusion here, there still remains a debate of whether EEG guidance, EEG-guided anesthesia impacts delirium and neurocognitive disorder outcomes. So that's because of all this conflicting data between these trials. And then for post-op risk factors, there's several well-established ones, such as PACU, delirium, ICU stay, sepsis, benzos, anticholinergics, infection, hypoxia, and so on. But not on here is opioids and specifically meperidine, which has been shown to be a positive risk factor for delirium in the post-op period. Pre-op screening for PND is recommended in the 2025 ASA guidelines. Screening should be for patients over 65 looking for cognitive impairment, frailty, functional status, mood, and other positive risk factors. Cognitive screening tools that are recommended are the MiniCog and the MoCA. So MiniCog is preferred as it's only 3 minutes long and has been validated in geriatric surgical patients. A score of 2 or less identifies patients at 4.5 times higher odds of getting post-op delirium. And the MoCA is 10 minutes long, it's more detailed, and can identify patients with mild cognitive impairment. The MMSE is another widely used tool, but it's not recommended for higher functioning patients as it's not as sensitive. So an example of how the screening tool could work is if a mini cog is done in pre-op consult, the patient is screened positive, then you could identify them at risk, and then you can refer them to geriatrics or pharmacy so that they can employ prevention strategies, which we will talk about. This is what the MoCA looks like. It's out of 30 and assesses several different cognitive domains. And beside it is the mini cog, which is quick to use. It's only 3 minutes and it's only 3 steps. It's a 3-word recall test and a clock drawing test, and the total score is out of 5. In terms of risk stratification, there are a few different risk scoring tools which exist for post-op delirium. Identification of risk factors using the pre-op screening tools like MiniCog or MoCA enables targeted prevention strategies that can reduce delirium quite a bit by 40%. However, for stratifying risk or calculating risk scores, the ASA does not endorse any risk calculation tools. For example, the Marcantonio clinical prediction rule was an old screening tool that was widely used. It's not discussed or recommended in the ASA guidelines in 2025. Over the years, there have been many other risk factors identified that are not included in this list, so maybe this will change over time, but as of now, risk stratifying is not recommended. In terms of preventative strategies in the pre-op and post-op time course, there are 5 major non-pharmacological strategies. 1 we talked about is pre-op screening. 2 is cognitive prehabilitation using tablet-based brain exercises. This has been shown to significantly reduce delirium and neurocognitive disorders. 3 is physical prehabilitation with exercise, nutrition, and anemia correction, showing a modest effect on delirium reduction. 4 is post-op multi-component, which I'll talk a bit more about in the next few slides, but it has been shown to significantly reduce post-op delirium. And 5 is a geriatrics consult, which has strong evidence that it reduces delirium by 36%. So I'll talk a little bit more about these two. So cognitive prehabilitation is the concept of building cognitive reserve through brain exercises like crossword puzzles. In 2021, there was the first large-scale RCT of cognitive prehabilitation, and half of the patients were randomized to cognitive exercises on a tablet, and they found delirium was reduced from 23% to 13%, even with minimal compliance in the activities. So this is a promising new strategy for preventing post-op delirium. The Hospital Elder Life Program, or HELP for short, is now in over 200 hospitals around the world, including at Foothills in Calgary. This method includes a 6-component bundle, looking at physical activity with early mobilization, reorientation with clocks and calendars, and communicating with family and friends, clinical medication review and avoiding benzodiazepines and anticholinergics, sensory stimulation with glasses and hearing aids, environmental control such as reducing unnecessary lines or monitors, and relaxation with a consistent sleep protocol. A meta-analysis of 14 studies showed a 53% reduction in delirium with this method. Some intra-op strategies we could use would be perhaps avoiding deep anesthesia or burst suppression with EEG monitoring until more conclusive evidence is shown. Cerebral perfusion, hypotension, and BP variation being risk factors for PND, we should try to optimize these parameters intra-op as well. We saw that GA and regional are comparable in their risk of PND, and TIVA might be better than volatiles, but we still need some more conclusive data on that. But something that does have significant amount of strong research for is the use of intra-op dexmedetomidine. So dexmed is believed to limit neuroinflammation and protect the blood-brain barrier and preserves physiologic sleep. So it's not surprising that it reduces the risk of post-op delirium and neurocognitive disorders. The 2025 ASA Practice Advisory analyzed 31 RCTs and found intra-op dexmed reduced post-op delirium by 42%. and delayed neurocognitive recovery under 30 days by 46%. And it also seems to have a reduction in neurocognitive disorders up to 1 year, although these studies looking at timelines up to 1 year were very small. So ASA marks this evidence as very low strength. Throughout all the RCTs, Dexmed sometimes started as a loading dose with a large range across studies from 0.2 to 4 mics per kilo, and all studies had an intra-op maintenance infusion, also with a large range across studies from 0.1 to 1.5 mics per kilo per hour. So these are the 4 ASA recommendations in 2025. First is to consider pre-op evaluation for inpatient procedures to reduce the risk of post-op delirium. They consider this low strength of evidence, however. They recommend choosing either regional or GA because there's no superiority with either technique in reducing post-op delirium. This is a strong recommendation with moderate level evidence. And either TIVA or inhaled anesthesia is acceptable for GA since evidence is currently inconclusive. And then they recommend considering Dexmed to lower the risk of post-op delirium. They classify this as moderate evidence and is a conditional recommendation, which is a bit of a surprise to me considering almost all the research was very positive. But they go on to say that you should consider the effects of bradycardia and hypotension, which is probably why it's a conditional recommendation. As you can tell, there's still a lot we don't know, and this remains a very active area of research to fill the knowledge gaps. There's a need for standardized cognitive follow-up beyond discharge. There's limited data on 3-month and 1-year follow-ups. These studies tend to be a lot smaller if they exist. And there's new research on genetic susceptibility, looking at ApoE, as well as non-invasive biomarker risk stratification for post-op delirium, which is an expanding area of research. So I'm sure soon we'll see if these studies will be helpful or feasible. And overall, we need more data on TIVA and anesthetic depth to have more conclusive evidence on whether or not it does impact post-op delirium or neurocognitive disorder rates. So going back to the story of Mr. R, he was independent and cognitively intact pre-op, presented for elective hip arthroplasty for osteoarthritis, and post-op he developed post-op delirium, delayed neurocognitive recovery, and major neurocognitive disorder at 1 year with loss of independence, which took a toll on his daughter, who is now his part-time caregiver for him. He did have a few risk factors like older age, diabetes, and depression, but these were not really screened for. These, it was just preoperative MoCA that was normal. So what could have been done differently here to prevent his post-op cognitive decline? So we could have quickly screened the patient for risk factors for delirium and inform the patient that they are at risk of developing a post-op neurocognitive disorder, including losing their independence. Since it's an elective surgery, it is possible the patient would have not gone through with the surgery, especially if they don't have anyone that can help take care of them afterwards and they do want to go home. If the patient accepts the risk, then pre-op non-pharmacologic prevention strategies could have been used, such as cognitive prehabilitation, like those brain exercises or puzzles, and physical prehabilitation, like exercise and anemia correction. And then intra-op pharmacologic prevention strategies of Dexmed infusion and post-op 6-component bundle could have been used with early mobilization, reorientation, medication review, reducing unnecessary lines and monitors, and following a sleep protocol. And then hopefully with all of these, his post-op trajectory would be different and he would still have his independence. So overall, PND is the most common complication in patients over 65, and these PNDs are largely preventable. Anesthesiologists are in a unique position to lead peri-op brain health initiatives, starting in pre-op consultation. Pre-op screening, intra-op techniques, and the various post-op strategies can make a significant difference in reducing peri-op neurocognitive disorders. So thank you so much for listening, and I'd also like to thank Dr. Liban Mohammed and Dr. Derek Delane for providing me with some insight and some material for this presentation. That is all. So if anyone has any questions, I'd like to also just open it up to discussion at this point as well. Yes.
Hi, Sid. A couple questions. First question, when did I hear for the that or the stuff?
Yeah, so that was post-op. Intra-op, let me just go back to that slide. Yeah, so post-op, we do know that it is a risk factor for post-op delirium. It's a bit unknown about longer timelines, like for delayed neurocognitive recovery and patient past 3 months. There's not much data on that. But for pre-op, let me just double check.
All right.
Oh, intra-op. Yeah, sorry. Intra-op, there's not much data on this as well. So not entirely sure. Yeah.
And my second question is, if you were doing screening for above 65 years age, to have risk factor like diabetes, do you think would include counseling for them, like that you are you counseling, you include that social you tell them about?
Yeah, I think that's a really good question. I think that's a really good idea to just let patients know that they are at increased risk if you do identify some positive risk factors that they have, just so that they're aware and they can make that decision themselves, whether they want to go ahead with an elective surgery or not. I think that's important to discuss in the pre-op assessment. Yeah.
So how do you do that? You screen them, who's the one?
Yeah, so using the MOCA and then also just taking a look at their past medical history. So if they have diabetes or any of these risk factors, like the ones here, I would just let them know. Right now, there's not really a risk stratification tool. So there's nothing that's recommended to use to let them know what their risk is. So we can't say that their risk is 10% or 50%, but we can just let them know that they are at an elevated risk. This is something that ASA recommends.
There's a question like some patients ask like about dementia. I haven't had to say that my dementia. So how would you answer that question?
Yeah, I think in terms of dementia, I believe it does make it worse. Especially in the immediate post-op period, they're definitely at higher risk of getting post-op delirium. Yeah. Yeah, it's definitely one of the risk factors. So I would answer that as yes, it's likely to make your dementia worse. Yeah, Kieran.
Depending on when I look at kind of like even let's say wheelbase small, I notice that like for the pattern stuff this trying to have the new top as a part of it, but a lot of us are moving towards moving towards
Yeah.
for these patients, maybe I was thinking like a lot of them for elective will also get a sort of kind of pre-operative screening when we do their medications.
Yeah.
And maybe that's a place that we can kind of look at implementing, but I think that's going to. It's just I don't think it's hard to kind of think over the phone and even on have that in this manner. You might not actually see it as well.
Yeah. Yeah. Yeah, I completely agree, especially with those assessment tools like the mini cog or the MOCA, like that has to be done in person. So our virtual PAC consults, this is not really feasible. It would have to be a patient that is already in hospital and we can see them in person. Yeah, exactly. Exactly. So is this really feasible? Probably not. But yeah, exactly. Exactly. Yeah, you have to know how to use these tools. You can't just grab a form and go up to them and start using it. So yeah, you do need to be trained in these tools before you use them.
It's just a perfect insight. I want to be sure that you're still doing it fast. when you were saying that it will make your dementia worse, are you saying from, yes, because there's a higher chance of breathing, which is associated with decreased function or maybe that one, or is there evidence to say for sure some people are dementia?
So I didn't actually look into that research specifically, so I don't entirely know how patients with dementia after surgery, they definitely are at more risk for post-op delirium. But then at the 3 month mark and at the 1 year mark, how much worse is their dementia? I'm not entirely sure. Exactly, exactly. Could just be normal progression of their disease. Yeah, yeah, that's a really good point.
It can.
Whatever it is. Yeah.
This looks like what kind of anesthetic you get doesn't really make a difference.
Yeah, which is interesting. Yeah.
So is it more related to surgical response, the body surgical response?
Yeah, that's one hypothesis.
Surgery itself?
Exactly.
Is it correct to put it on anesthesia that it was
Yeah.
control DMD?
Yeah, that's a really good question because even in the general anesthesia group that excluded sedation, there was still no difference between the regional versus general anesthetic group in terms of post-op delirium. Those outcomes were very similar. So I think there's definitely some hypotheses that I was reading about that is it really due to the anesthesia stress or is it due more so to the surgical stress? And yeah, that's a really good question. Maybe it is due more so to the surgical stress as these studies are highlighting.
Should the surgeons count?
Yeah. 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 Shared responsibility with the surgeons for sure. Yeah.
Yeah, exactly.
Yeah.
So patients will be taking.
Like blaming. No, that happens.
But it's not about blaming, it's about who does the cleaning, who does the counseling, who does the man.
Or what Don exactly said about, like at the beginning when we say, you know, we're the risk of that and blah, blah, blah. I think just even making people aware that this can happen and families aware would
Yeah.
probably take some of that stress. So like if you come in and see your family member, you could be like, oh, I was warned of this. It's hopefully it's just postoperative delirium, they're gonna improve, right? Versus what is happening in my mom or dad is not the same. So there's value in us just mentioning that this could happen when they have some of those risk factors.
They'll say, oh, nobody told me about this.
Yeah.
Yeah, exactly.
Yeah, it's horrible.
This whole process starts from when the surgeon talks to the patient. If you read a lot of the surgeon, they do talk to the general.
And the ethics
Yeah.
Too. And they do mention that a lot, but still, they set the scene so that patients know what they're
We want to
expecting.
hear what they want to hear. We can't control that, but we can still say it. And if they hear it enough,
But
they.
by the time.
Yeah.
Wanted to do something like that, they just started.
Yeah.
And then.
I do well, like, yes, it should done like, on that, just the patient, you did, or said you would like. Hey, like, patient getting back, and it's a serious sign, like, when we actually go through that. So if you're crossed by that, no.
Yeah.
But like, part of it is just coming to the whole thing, and us saying, we're at risk of delirium, and when we want to find afterwards, the family would know that I talked about that. And I see them on the day as well, just tell their family member, like, they might be a bit cleaned up, they're doing that, generally gets better, you know, they want some respect for this. And then, at least they've had a little bit of, you know, that impact, and then they're maybe very slightly more prepared than they have. And then all of the stuff that Jessica said, yes, it's not definitive evidence for each one of our steps, but in general package of us being a bit more aware of like what we're giving to the patient, you know, being shed blood pressure okay, in about one acts they're giving, you're doing too much, whatever it is, and then that stuff to do with that is then helpful to their brain. And all of that stuff is help, like it's not unhelpful to do that stuff, it's just big. It's, I agree exactly, like I'm not saying that or we're not the next year after surgery, but we have like a little runny.
Instead of that, adding over patients on once in pilot, get everything immediately. The more quicker, complicated, when it goes here, you need to and you want to do processing on. There's a lot of those factors. The little rehabilitation coming due to information. Good idea. Yeah, that's more comfortable with that. Yeah, you kind of passwords available, any kind of.
Because usually take about a good amount of time, like 9 months. Yeah, I think we could. Yeah, I think that's a good idea.
And so he's when I was working on the presentation with Jess, that's the first thing I thought, like, hey, look, something you can add when you already decent both for the game.
Now we're doing hips and knees, base surgery, right? So that.
There is a question on Zoom as well. Do you think the reductions in risk driven by DexMed in targeting lower depth of anesthesia work by reducing hyperactive delirium in the early post-op period, which may be more likely to be recognized than hypoactive delirium? I think that's a good question. So definitely hyperactive delirium is very easy to notice. Patients are very combative. They start pulling at lines and tubes. They're very difficult to unpack you for the nurses. So we hear about them a lot. But hypoactive delirium sometimes just looks like patients staring blankly at a wall. So it is a little bit more difficult to identify. So that is definitely a plausible hypothesis there. And why the reductions in DexMed and lower depth of anesthesia could be working more so to just reduce hyperactive delirium. Yeah, that's possible. And I don't think these papers looked at specifically hyper and mixed and hypoactive delirium. It just kind of put them all in one group. So we don't actually know. Thanks for the question. Okay. Yeah. Okay, thanks.